He has always marveled at the abilities of the nervous system. His current company, Dignified Therapeutics, where he is Chief Scientific Officer, is focused on bladder, bowel, and sexual dysfunction associated with neurological disorders. Let's welcome Dr. Karl Thor.
Thank you very much. I appreciate y'all coming and giving a talk about the bladder after you've been sitting for an hour after drinking beer. It's sort of a little bit torture, so I don't expect too many questions at the end. So we're going to talk about control of the bladder, neural control. And one thing I'd like you to keep in mind through the talk is that you can walk at about 1 year of age. You can start to talk at 1 year of age. But to control your bladder and bowel requires you to reach the age of 2 to 3. Why does that happen? That's kind of crazy when there's only 2 functions for what the bladder should do, for example. It's a reservoir. It holds urine in the bladder. There's an outlet called the urethra, and there's a valve in there, the sphincter. It's a very simple function, but all 3 divisions of the peripheral nervous system, the parasympathetic, sympathetic, and somatic system, innervate the lower urinary tract. The parasympathetic makes the bladder contract. The sympathetic makes the bladder relax, the opposite, and it contracts the sphincter, and the somatic closes the rhabdosphincter. Now, you can't have all those nerves working at the same time or be completely dysfunctional, so that activity is controlled by reflexes in the central nervous system. So you have these storage reflexes that as the bladder starts to stretch, the afferent fibers start to respond, and they activate sympathetic neurons to release norepinephrine to cause beta-3 activation, which causes relaxation of the bladder smooth muscle. Norepi activates the alpha-1 receptor to cause constriction of the urethra. That helps you prevent urine loss. In addition, these same receptors activate your somatic system to make your external sphincter tighten. And when the bladder is, you also have voluntary control. So if you're writing your name in the snow and you want to stop, and then so you can get your second name in there, well, that's your voluntary control of your external sphincter. It's also activated when you cough, laugh, or sneeze. Now, when the bladder gets distended to the point that it's starting to reach its maximum capacity, these stretch receptors tell the periaqueductal gray, hey, we're getting full here. Periaqueductal gray then tells the rest of the brain, hey, we got to take care of this situation. The brain says, okay, and the periaqueductal gray then activates the pontine micturition center, which then descends to activate the parasympathetics, which makes the bladder contract. In addition, this pontine micturition center really coordinates that contraction with relaxation of the urethra and the sphincter by inhibiting these storage reflexes. So this is a sagittal section diagram through the entire central nervous system. And these neurons that control, the bladder, the sphincter motor neurons are known as nucleus, and the parasympathetic neurons, they're in the sacral spinal cord, the very distal end of the cord. The sympathetics are at the upper lumbar level, and then these pontine micturition center and the periaqueductal gray that are so important for coordinating activity, they're all the way up in the brainstem. Now, those are the relay places for these reflexes, but superimposed on all of those reflexes are inputs from the basal ganglia, and one of the first symptoms of Parkinson's disease is actually bladder and bowel dysfunction. You also have the medial prefrontal cortex, and one of the first symptoms of microvascular accidents, mini strokes in the prefrontal is, again, bladder and bowel dysfunction. Then, of course, you have all the rest of the hypothalamic and monoamine cell groups that all regulate this entire pathway. And this is sort of the connectome for the bladder control. As you can see, it's pretty complicated. So with that in mind, whenever you have a spinal cord damage, of course, the bladder loses its ability to tell the brain it's getting full. The brain loses the ability to activate these sacral reflexes. The inhibition of the storage reflexes is gone, and all you're left with are the storage reflexes functioning. And so, of course, when the storage reflex functions, you can't void. So these people are unable to void. After a few weeks of the bladder being overfilled and distended, it gets irritated, pissed off, and these C fibers will start to then activate these parasympathetic neurons, but they're very weakly activated and it's not coordinated, and they still have problems with their bladder being overactive, but they still can't void completely. So over 2/3 of people with spinal cord injury require inserting a catheter through their urethra into the bladder to drain the fluid, which isn't any fun if you've had it done. And to bowel void, they actually have to stick their fingers in their rectum and swirl the finger around to stimulate the mechanoreceptors in the rectum to activate the colon, to push the stool down, and then they have to manually extract it. They use enemas and they use suppositories to help facilitate this activity, but it's still a terrible way to deal with the problem. So our mission at Dignify is to restore this voluntary control for people with neurological diseases, diabetic neuropathy, and the elderly. And what we're developing we have 2 programs at the moment that are getting pretty close to clinical trials. We just got a grant for the sublingual tablet to go into phase 1 trials. And we also have a suppository program with a different mechanism of action. And both of these drugs, you take them within 5 minutes, you void, and within 10 minutes, the drugs are completely gone from the system. And so that's what we're trying to do, and I appreciate your patience, and if you have to hit the men's room or the ladies' room, feel free. Thank you very much.
Are there questions over here? I've been neglecting this side of the room. Now I'm putting them on the spot. There we go. Bold person. Here you go.
So is there a genetic component with the ability or disability to void from the time, like bedwetters or kids that can't hold it, that continues into adulthood?
There are no known genetic factors that are correlated with bladder and bowel conditions that I'm aware of. Nocturnal enuresis is still a mystery. It is associated with later some mental illness, that sort of thing, but it really hasn't been tied together.
I'm going to go down here. Pass that down. Sorry. Sorry. Pass that down.
Hi. I believe there are some advances in using vagus nerve stimulation, like devices that are actually implanted to treat incontinence and other bladder control problems. How would you compare the pros and cons between those 2 solutions, both the vagus nerve stimulation and the one that you're discussing here?
Yeah, the vagus nerve stimulation is a really remarkable depression, epilepsy, obesity, but it's not used for the bladder. What we use for neuromodulation of the bladder is sacral neurostimulation. So they stick an electrode through the sacral foramen at the S3 level and implant a stimulator. And that helps a lot, but it doesn't completely eliminate the incontinence. And someone who has no voluntary control over when they want to urinate, it doesn't provide them with an on-demand mechanism for them to void when they want to. So it's definitely a step in the right direction. One of our products is actually a neuromodulation device for the pudendal nerve. But I'm not talking about that today.
Yes, I have a question in regards to a lot of times with women who have children or have multiple children and or don't have children, but still have trouble when they get in their later years to control their bladder. So is there anything they can do at that point, or has the damage been done and there's nothing that we could actually do to help prevent, if you sneeze or cough and you're still wet?
Right. So the conservative treatments are Kegel exercises, general general exercises to strengthen your pelvic floor muscles, that helps a bit. Not smoking reduces your coughing. Obesity, losing weight makes it less likely. My first drug on the market was actually for stress urinary incontinence. That's the next level up. It's not approved for that in the US, but 51 other countries internationally it is. And then this neuromodulation device I was telling you about should help with stress incontinence. So at the moment, I think exercises of the pelvic floor, behavioral feedback therapy, that's where you want to start.
One more question.
So I'm not sure how to phrase this question, but there was a few years ago I was taking OxyContin for medical reasons, and it really constipated me. And the only solution was pills and whatever to address, I guess, the physical symptoms of constipation. I'm wondering, okay, so this is kind of like with the brain and the physical and whatnot. What is the connection between OxyContin, the drug, and constipation, and what do you see on the horizon? Is there anything that will help a person in this situation?
Yes, so OxyContin also causes urinary retention. That works in the central nervous system at both the spinal cord level and up at that periaqueductal gray, which is important for pain, which is where morphine works. So that's part of it. And again, the GI tract also uses those same regions of the brain. So they're being affected there. But more importantly for the GI tract is that the peristalsis that you have that gradually moves, you need this relaxation and then a contraction. And the morphine blocks that relaxation of the anterior portion of the GI tract to allow it to accept what's coming down the tube. In regards to therapies, there are now some peripherally restricted opiate antagonists like methyl naltrexone. And so they seem to work fairly well at the moment. And again, diet and all those other things are important.
Thank you so much, Dr. Karl Thor. Thank you.